So and I'll recap that bit for the recording, and Caroline will upload the recording for you, so I do apologise. I was thinking I was getting off to a good start there. So it is important, but it's also about doing the assessment, but it's also about recognising what you're assessing and to be able to interpret what that actually means in terms of what action you might need to take. Some of these terminologies you will come across, some of them you may not have done. In terms of your anatomy physiology, ventilation is about getting the air in. Diffusion is about the transference of gases across the alveoli into the bloodstream, and perfusion into the bloodstream. The respiratory drive is to do with the respiratory centre in the brain, responding to sensitivity to oxygen and carbon dioxide levels in the blood. And respiratory rate, I hope you know what that is. So it's the speed at which breathing takes place, recorded over a minute. Some of these other ones are, again, in there. You may see them. Some of them are Greek or Latin, and apologies for that, but you will see these terminologies discussed or used. So bradypnea is slow, brady. You may have talked about bradycardia, slow pulse. Bradypnea is the same. Cyanosis is something that you may hear talked about more often, and I'm going to talk about cyanosis a little bit more in a minute. Dyspnea, difficulty labour breathing. You will hear that terminology, or you will see it written in patients' records. So there's a hyperventilation and hypoventilation. Hypoxia you should have come across when you're doing your biology, but you will see it talked about in practice. And again, hypoxemia. Orthopnea is something you'll see written when patients on a patient assessment. So it's breathless unless they're sitting up, right? And tachypnea, respiratory rate, more than 20 breaths a minute. Again, easy to look up, think back and refer to. A few bits of terminology for you. So when do you undertake a respiratory assessment? Well, we've talked to you already about the initial patient assessment of all the vital signs to get the baseline, to see how they are, and then of course assess and monitoring patients as an ongoing process, and so that you can identify changes from your baseline, particularly following surgery. Anaesthetic gases alter the rate of respiration and can change and alter conscious level in order for surgery to take place, and it's really important to monitor that the patient is breathing and ventilating well post-operatively. So those of you that might have had a surgical experience or going to go into surgical experience, you'll find when you're monitoring patients that have had surgery, you'll be doing frequently respiratory rate as well as other vital signs. So respiratory rate, if you're going to do some investigative procedures, so I've talked about having anaesthetic, but when we talk about investigative procedures, we're talking about ones relating to respiration. Obviously, if somebody's had chest trauma with fractured ribs, etc., or in emergency situations, you are going to be assessing their respiratory rate. Again, if patients are receiving intravenous fluids, then there is a risk that if you overload the cardiovascular system with your intravenous fluids, it's going to have an impact on gaseous exchange because of the way the heart pumps blood straight into the bronchial tree for gaseous exchange, and problems with that can cause backflow, and you will note a change in respiratory rate and respiratory indication of the signs, which I'll talk about in a minute. The other thing with blood transfusion, it's the same thing that I've just discussed, but in addition with transfusion, you're looking for people reacting to the blood that they're receiving. So essentially other interventions. I've already talked about anaesthetics, opioid analgesia. This is your morphine, your diamorphine. You may have picked this up when you've been looking at drugs, that it causes depression of the respiratory system, so somebody can stop breathing if they're on opioids. Oxygen therapy, you need to do record respirations to aid in determining that the oxygen therapy is being effective. Bronchodilators and medications given to open the air passages. And again, that sort of observation that takes place. And then we're looking about deterioration, respiratory status. People who've got long-term respiratory conditions will have evidence of breathing difficulties. It's quite a range of things there. So we're going to prepare our patient. We always talk about this to you from the start when we do skills about gaining consent from a patient to take their vital signs. But of course, we've already explained to you, and you've already considered that if somebody knows that you're taking their respirations, then they may actually start altering their breathing pattern. You may have found that out when you've tried it out on each other in skills. So again, what we usually say, can I take your pulse and your temperature and blood pressure, and you'll bring your respirations into that. It's important the patient's rested, not engaged in any physical activity, because if they're breathless and they've engaged in physical activity, then that might be okay over a short period of time. And all of us, if we ran a certain distance, we would be breathless when we finished. Even things like somebody walking from their bed to the toilet, for example, or walking around. So they need to have been rested for a few minutes beforehand. You need to have them positioned, as in our picture here, so that that they get good lung expansion, and you can look to see for signs of difficulty in breathing. If you remember, I talked about orthopnea, breathless when laying flat. That is an important thing as well. But essentially, this is how we like our patients to be. So we're going to look. So when you get the presentation, you can click on and have a look at the little video to see what you're looking for, to reinforce the points I'm making. So we've already talked to you about why you record the respiratory rate for a minute, especially as you are looking for patterns of breathing, and therefore if you do it for 15 seconds or 30 seconds, then you may not be able to note that there is a change in patterns of breathing. So you're looking to see how deeply they're breathing. Is it shallow, or is it normal, or is it deep breathing? How regular is the breathing? Is the breathing pattern a regular breathing, as most of us sitting here are, or is it irregular, that there'll be a few breaths, a pause, or a deep breath and then shallow breaths? Quite a range of things you could be observing for. Worker breathing is a term used for how much effort somebody is putting into actually breathing whilst they're resting. How much effort is the worker breathing? So are they using accessory muscles? So accessory muscles of ventilation is your shoulder girdle. Now, all of you are probably sitting, and if you breathe in and raise your shoulder girdle, raise your shoulders while you take a breath in, you will feel more air being sucked in. So people who have got respiratory problems quite often will be using extra things to aid that air coming in, and using accessory muscles of ventilation is one of them. So dyspnea, are they struggling to breathe? Are their lips pursed? A little picture for that should be come up. Yeah. Are you seeing this? Now, the reason for this, in long-term respiratory conditions, when there's damage to the bronchial tree and alveoli, and gaseous exchange becomes more difficult, then if you purse your lips as you're breathing out, it will actually force air to stay in the alveoli longer. It's not a conscious thing that people do. It is something that is a compensatory kind of thing to try and aid gaseous exchange. Nasal flaring, which I haven't got a diagram of, but if you take a deep breath in and really struggling, you might find your nose flaring, so your nose opening more, again, to aid oxygen to get into the system. And these are physiological changes that happen to people with long-term conditions. So breathlessness, dyspnea, it is a substantial effort required. I've asked you to raise your shoulder girdles to take a breath, but if you sat there and do that for quite some period of time, you may actually find the effort quite difficult. So there are these kind of things to consider. The other analogy I use, if you think about when you see the Olympics or the European Olympics or the European Games, specifically the 100-meter runners, maybe Usain Bolt slightly out of it, but you'll see this as well. So at the end of the race, everybody is bending forward, hands on their knees to take some breaths. Again, this is something that happens with people that are breathless. If you lean forward when you're breathing, your intercostal muscles at the lower end of your chest will again increase the lung capacity, will aid into that breathing. You'll also see them pursed lip breathing, by the way, at the end of the 100 meters. So that pursed lip breathing and that deep breathing, leaning forward. So if you're seeing people who are breathless, who are better leaning forward to their breathing, it's an indication that something's not right, and you will see this in long-term conditions. And you'll see sometimes people with long-term breathing conditions will sleep in chairs, will have tables in front of them to lean over, and you will also see this in their home, and you'll see this in hospital patients. And again, it's all indicators that things aren't working so well. So it can be a result of airflow obstruction. So something's obstructing the bronchus. If it's asthma, it's spasm. We're going on to talk about asthma in a moment, bronchospasm. Or if it's COPD, it's due to degeneration, deterioration of the alveoli. If somebody's got a chest infection, you've got a lot of mucus production, and therefore mucus blocking off the alveoli means that, again, automatically the body system will try and do what it can to get more oxygen in, i.e. increase breathing rate, and that's always the automatic thing, increase the breathing rate, as well as the other things that I've been discussing. So, okay, I'm just going to have a look at some of your questions at this point. Oops, she says, having looked at them and shut them down, don't worry. I shall bring those up. Just give me a tick to have a look at the questions. Somebody's asked me to speak a little slower. Sorry about that. I will. Okay. Let's have a look at what else you're asking. Okay. PowerPoint's going to be loaded up later. So why does oxygen have to be prescribed? And what are the contraindications? Where do you stand putting oxygen on someone who needs it but it's not prescribed? That's a really good question, and one that comes up quite a lot. Oxygen needs to be prescribed to ensure that the right amount is given to somebody for what they require. So oxygen is prescribed against what somebody's saturations are, oxygen saturations. So you use, the little probe where you put them on the finger and measure oxygen saturations. The other thing is, we'll talk about in a minute with COPD patients, a small number of people with COPD retain carbon dioxide, and therefore you need to be very careful about what oxygen you prescribe them. And I'll explain it when we get to that point, but too much oxygen will stop breathing. So we need to make sure it's prescribed to make sure the people get the right amount. There are some research papers on that, and I believe I'd probably put them on the end about oxygen therapy and why it needs to be prescribed. So where do you stand putting oxygen on somebody who doesn't need prescribed? Nurses can put oxygen on somebody in an emergency situation. In an emergency situation, if somebody's become suddenly breathless, then high flow, 100% oxygen can be put on and get a doctor's attention. You should not be administering oxygen without prescription. The reason why is, and the research papers will show you that inadequate amount of oxygen is often given to patients with breathing difficulties, and therefore it needs to be prescribed against taking blood gas analysis. So blood gases are taken from a sample of blood from usually the radial artery, and you get blood gas analysis and you get to know exactly how much circulating oxygen, how much circulating CO2 a patient has, and can determine accurate therapy for them. You can put, as I said, you can put oxygen on an emergency or a situation where somebody's deteriorated, but you need to get the medical attention. So what you'll see when oxygen is prescribed, it will be prescribed to maintain a certain saturation rate, and therefore you will be monitoring somebody's saturations. Okay, somebody's asked about retainer. I've just briefly outlined that. I'm going to talk about that in more detail with CO2. Yes, your oxygen is to be prescribed on a drug chart. Thanks for those questions. That's really good. Right, I'm going to continue. So, characteristics of breathing. I think I've probably got over to you that it can reveal specific irregularities and which demonstrates that there's poor gaseous exchange taking place. You may hear the term Cheyne-Stokes respirations, irregular breathing pattern and short periods of no breathing. It's a pattern of breathing that takes place just before death, and quite often it's an indicator sign that nurses and medical staff will recognise. Having said that, people can go on for several hours or even a day or two Cheyne-Stokes breathing, but eventually it's like an indicator of imminent death. Cushman's breathing, again, air hunger, deep rapid respirations, respiratory centres trying to compensate, trying to equalise the oxygen and CO2 level in the blood. And what happens is in respiratory acidosis, where acid builds up in the bloodstream, you get very, very rapid respiration. The reason why the body is doing that is to get rid of the CO2. CO2 is carried in the blood as a carbonic acid, and the body measures the amount of acid in the blood. So you have receptors in major arteries like your carotid arteries that are continually monitoring the acidity of your blood, and also to a lesser extent the oxygen level in the blood. And depending on the balance, to get the balance correct, then the respiratory rate will be adjusted. So let's look. What are we looking for? Well, we're looking at all the things I've just been talking about: the respiratory rate, the pattern of breathing, how much effort is required for the breathing. And the other thing I briefly touched on earlier, and I knew I was going to come on to it, is about cyanosis. So you're looking at two things. You're looking to see the signs of cyanosis, central, peripheral. The first photograph here of the fingers, dusky purpley colour, is called peripheral cyanosis, and you will see this in toes as well. However, cyanosis is also a sign of cardiovascular disease. So if the heart and vascular system isn't pumping properly around the body, then oxygen won't get to the extremities, and so you have cyanosis. But if you've got cardiovascular problems, you usually got respiratory problems linked in with that when you get to this stage. So it's an indicator. The other thing, we've just been talking about SATs. If you use a SATs machine on somebody who's got dusky purpley fingers, then the infrared light, the light isn't going to be as accurate a measure, because it will be dark all the time, so you won't get an accurate recording. It's a great ready reckoner, but there are certain things that affects SATS machines, and this will be one of them. Nail varnish is another one, just for a tip there. So central cyanosis is seen in the oral mucosa. So you've got some slightly blue dusky lips here, but if you ask the person to open their mouth and look inside the mouth, all of the oral mucosa will be, again, this dusky purpley colour. So hypoxemia, lack of circulating oxygen, and I've also talked about peripheral vascular vasoconstriction in terms of if we've got heart disease problems. The other thing you'll see medics look for is for clubbing, finger clubbing. Here we have a diagram here. It's an indicating long-term chronic cardiac and respiratory problems. It is what's called unknown etiology. It is unknown why fingers change into that shape with long-term respiratory conditions and cardiac conditions, but it's an indicator. However, something like 12% of the population have club fingers with no associated cardiovascular disease. So the thing I'm going to say to you is talk to you about next time you come across patients with breathing difficulty, the people with long-term lung conditions, is to have a look in their notes and look at the assessments that the medical staff or the advanced nurse practitioners do, and look at the things that they document, and finger clubbing, cyanosis, respiratory rate, all those things will be listed. Let's talk about sputum. So I'll just have a drink, for my throat's dry. I must admit I'm not a brilliant keen fan of sputum. I don't many people are, and I wondered why I ended up working in a respiratory ward when I kind of like, and all of you may have gone, ugh. However, sputum is a really good diagnostic sign. So expectorating means coughing up or bringing up sputum, and it should be observed. You're looking at the colour, you're looking at the odour, how sticky and consistency was it, watery, how much is being produced. People who are producing sputum, each day you should check to see what their sputum looks like, how much they're producing. So again, it's looking in that pot, because if they're not improving or they're getting worse, then their lung problems, you're going to see more. If they're improving, you're going to see a change. So green, yellow or creamy sputum. Purulent means plenty of, means it's infected. Nice little picture here of a good lumpy tenacious bit of sputum. White, frothy or pink sputum, which we have here. Pink it will be rupturing of small blood vessels. This is called pulmonary edema. This is due to fluid overload backflowing from the heart and passing out into the network of capillaries around the biliary tree. This is effortlessly filling up, and patients may just bring this up just constantly, effortlessly. If this is the case and they got pulmonary edema, they are extremely seriously unwell and will need to have treatment. The treatment for this would be to give intravenous diuretics to remove the excessive fluid load around the body. So, and also reduce, other drugs will be given to reduce the effort that the heart is making, because essentially they'll go bang. You'll hear the term drowning in their own sputum. It is highly unpleasant for people, and they do need lots of care and care with the personal attention you give them, but also their psychological care of going through this experience. Blood in sputum, here's a diagram here, frank blood or hemoptysis, indicative of carcinoma, and you should have seen the adverts on television. If you've got a cough for more than 3 weeks and if you're coughing up blood, then go to your doctor. What's happened is a tumour's eroded into one of the blood vessels, again the fine network or more. I will say that most lung tumours, by the time you have symptoms like this, things are not good. What happens, because you've got such a great lung capacity, you will compensate, and quite often people won't notice that they've been getting increasingly breathless or having any breathing problems at all, especially if you're smoking, because they talk about things like smoker's cough. And so if somebody's got a cough and they smoke, then you might not recognise that that's an issue, or you might not recognise that you are slowly having breathing difficulties. Pulmonary embolism, blood clot lodged in the blood vessels around the bronchial tree. That would be associated with acute pain on breathing. And the other thing, of course, is blood in sputum trauma. I talked about fractured ribs. If ribs are fractured and they injure the capillaries around the biliary tree, then you'll get some seeping into the alveoli. Black specks of sputum, smoking, cigarette smoking, smoke inhalation. So if somebody's been in a fire, you may find them coughing up little chinky chunks of black stuff. Lovely. Okay, this is the reason why you may or may not know, if I've clicked the link now, there's a time delay in terms of the streaming and you don't actually get the benefit, but as I said, you'll get the presentation. Go and listen. This is a recording of different sounds of what you would be listening to with somebody with breathing difficulties. A lot of you have cared for people with breathing difficulties and will know how things sound, feel. Okay. So chest movements should be symmetrical. If one side of the chest is rising and falling and the other side isn't so well, you might suspect a collapsed lung, or you might suspect that there's so much infection in there that things aren't moving too well. Most of you, we've talked to you about observing chest expansion, but actually you could actually feel to determine and develop. These are things that you'll see clinicians do, and that will do with putting both hands on the lower side of the chest to compare one side to the other. So if you can't see chest expansion, then you should actually feel. So placed either side of the patient's anterior, that's the top chest wall, thumbs should be together either side, chest midline. There's some diagrams. I've given you some links to some clinical skills sites associated with respiratory assessment, so do take a look at them. But this is what you'll see doctors do and advanced nurse practitioners do, and when we work in respiratory care, we're trained to do these kind of things so we can make these assessments. You also see physiotherapists will do assessments based using this skill. So if people aren't ventilating well, I'm using that word we talked about at the beginning, then the gaseous exchange is limited. Unilateral, I've just talked about. If one side is not working, the other side is, you've got to suspect a pneumothorax. Pleurofusion, that's fluid that's developed between the two pleura on the lung, and there's occasions with heart failure or carcinoma that causes that, and so the lung is squeezed, and I talked about pneumonia again. The other thing as well that I've not mentioned on here is if somebody has got a very bad chest infection or have got pleurisy. Pleurisy is extremely painful and it hurts to take a breath in, and so you may see again that restriction, not breathing so much on that side. You would with fractured ribs. And pulmonary embolus, pleurisy is very painful, and therefore you're restricting the breathing. Good pain management will enable somebody to breathe better and oxygenate themselves better, and therefore breathe better. Now, we've talked about pulse oximetry. This little video runs through how to do this correctly and talks about some of the good things. It measures oxygen. It measures how red the red blood cells are circulating. So it measures how red they are, because oxygenated blood is redder, and that's why if you put it on a finger that's cyanosed, it's not going to help and interfere. What it does not measure is carbon dioxide levels in the blood, and sometimes this is very crucial in determining oxygen prescription, and therefore, as I talked about, blood gas analysis. But it's really useful. It's a quickie. I know it shows the pulse rate too, but you're looking to see saturations. Normal saturations should be above 98%. However, people with long-term lung conditions may survive okay on lower saturation. Peak flow recordings. We're going to get you to be doing, you've been doing peak flow recordings in the ward, but we've talked about that. So looking at lung capacity, again, there's a little video here on how that's done, how you get the best results out of that. Spirometry. Some of you may have seen this with community nurses. Certainly if you go into GP practice replacement, you'll see people having spirometry. Spirometry measures more than just your peak flow. It measures lung capacity. Again, the same technique, you're blowing into the tube and record it. And if you watch this little video, then you'll see how it's done. Spirometry is a diagnostic tool to diagnose several things, but certainly spirometry is a sort of finite diagnostic tool. Spirometry and blood gas analysis will actually is used for diagnosing COPD, chronic obstructive pulmonary disease. I've talked about blood gas analysis. You're looking at, in blood gas analysis, you're looking at the oxygen levels, you're looking at the CO2 levels, you're looking at the pH, so you're looking to see the gas, and you can determine a patient's respiratory function on this, and you would determine how much oxygen therapy they require based on this. Exercise tolerance is another thing. Again, exercise tolerance where you would get somebody to walk a certain length, usually about 20 feet to start off with a SATS machine on to see whether exercise, i.e. walking, what we say desaturate, their oxygen levels go down. These things, all of these three things are used to determine in long-term conditions whether people need to have oxygen therapy at home. Some of you may have come across people with receiving oxygen therapy in the home, and to determine how much oxygen they require. These are some of the tests that they do. What am I doing for time? Okay, not too bad. So the key thing here then, evaluation documentation. Obviously, as we've taught you and you've learnt in clinical practice, do it immediately following assessment. You've got the time on there. If you're doing it for the first time, it's important to document in their records the rate, rhythm and depth to determine if they're in normal range. Then things can be compared to the baseline, and then the patient's history can be determined to look at their health and their deterioration and to decide on a plan for them. Right. So next question. So I'm going to have a look at yours, and then we're going to move on to some of the conditions that common conditions that we may care about. Oh, we've got loads of questions here. Right. Rick, you've been doing all sorts of things out in clinical practice, haven't you? Right, so coming along. How does a clip on the finger count the oxygen in the blood? So I've already said the SATS machine measures how red blood cells using the light, the beam system, the infrared system. So false readings, nail varnish. The equipment needs to be working. It needs to be fitting comfortably, because if it's not a good comfortable fit, if the spring in it is beginning to deteriorate, then you could get a false reading. They say in the literature that fluorescent lighting can cause false reading, which is interesting because in hospital we use fluorescent kind of lighting. Also, if people aren't keeping their fingers still and they're waving that around, that's another false reading. So those are the common ones. Okay, somebody's asking about oxygen and oxygen masks. You are going to be doing this in great detail further on. So there's a range of oxygen devices. Emergency situations, you're using those 100% non-rebreathable masks to get that 100% oxygen. Then what you'll have is you'll have a range of different oxygen percentage delivery devices. Depending on what oxygen the patient requires, you'll have 24%, 60%, 35%. So again, depending on what the doctor wants to prescribe. Nasal specs are used to deliver lower ranges of oxygen, and the maximum you can deliver through nasal specs is 40%, which is very, very uncomfortable. So people with long-term lung conditions who may just need a small amount of oxygen, nasal specs can be used. Nasal specs also give you the freedom to talk and eat and drink without having to take the system off. There are difficulties and side effects. Long-term oxygen use can cause burning to just below the nose because of continual oxygen going out. And the person has asked about humidification. So humidified oxygen should be humidified if it's going to be used continuously for more than 24 to 48 hours. If you think about it, when you're breathing, your airway, your mouth is moist, and also your upper airway, so your mouth, your nose, your nasopharyngeal area, it's moist. That idea is to moisten the air you breathe to stop your lung tissue from drying out internally. If you're giving oxygen flow, it is a drying thing, and therefore it becomes uncomfortable and painful, and actually you start to get if it becomes very dry, then you'll get reduced function because the mucosal level and the alveoli don't do well, and therefore you should humidify oxygen. Somebody's asked, will coloured sputum always indicate infection? If it's dark yellow and green, yes. Mouldy taste that patients complain about, yeah, you're right. If you've got infected sputum, so good mouth care, if somebody's coughing sputum, and inevitably it gets, if it's infected, it gets thick and sticky, and therefore it's going to, and it smells. I mean, you will smell sputum if it's infected. It does start to smell like, yeah, mouldy, like mushroomy taste smell. So it's really good for patients to have the opportunity to do mouthwashes or cleaning their teeth more often. The other thing you might see is people with very thick tenacious sputum receiving nebulized saline to loosen the secretions. The other thing that's really, or steam. So for example, so nebulized saline is like steam, and a cup of tea, actually the steam from the tea can loosen secretions, and you might find that in yourself. You might find that you've had your head over a bowl with towel on your head to loosen secretion. So a nebulizer does the same kind of thing. Okay, if somebody's sputum is becoming clear, it shows that things are improving. But on the other hand, you can get prolific clear sputum with certain diseases like cystic fibrosis or long-term COPD. You'll get, and asthma, you'll get increased production of sputum that might be clear. So it's there are things. So the other thing you might get with sputum is you can produce sputum, and it should be clear. We all do it. We're in the beginning to get into the hay fever season, so you get a lot of external mucus floating around and all that kind of thing. So if you produce sputum normally, but it starts to become prolific much more, then there is a cause concern. Does anybody have 100% oxygen levels? Yes, if you're administering 100% oxygen. You can do, if, again, people who are athletic, again, your lungs start to adjust. So you might find if somebody's, very fit, they can actually increase their oxygen levels. I know I remember one day when we were in skills, one of them doing oximetry, one of the students decided she wanted to run up and down stairs for quite a bit to see if it would increase her oxygenation from something she was about 98, and yes, it did for a very short period of time because she's, increased that level. Heck, you were asking some interesting questions. BiPAP, non-invasive ventilation, is used to open the air passages and keep them open, so when the patient breathes in, the air is forced in and it holds the alveoli and bronchioles open to prolong the opportunity for gaseous exchange. If you go back to when I was talking about pursed lips, so that's what pursed lips do, breathing through pursed lips, but actually using the machine to hold the alveoli open to increase the capacity for gaseous exchange. Pleurex chest drain is in place. Why is there fluid in the first place? Okay, if somebody's got a chest drain in, it's because they're draining fluid or air. You drain air if you've got a collapsed lung, a pneumothorax, or a punctured lung, and the negative balance within the chest wall, the lung collapses, so you have to put a chest drain into the space to drain that air out. If there's fluid in there, you could be draining fluid because there's a pleural effusion. You could be draining fluid because there's a somebody's had surgery. It's for very, very many reasons. So if you have a look at pleural effusion, it's probably what you're talking about, Rebecca, with a chest drain. Fluid building up in between the pleura, pushing the lung smaller and smaller, reducing the capacity for gaseous exchange. The fluid needs to come out. You can get pleural effusions as a side effect, or the complication, sorry, of pleurisy, where the fine fluid between the pleura is increasing in proliferation because you've got infection in there, and so you can get a build-up of that. But inevitably, it's to do with quite a complex system related to things like heart failure or lung cancer. You get fluid in the pleural space. Somebody said about putting the SATS machine on the ear. That's fine. If somebody's got peripheral cyanosis and you put it on the ear, then you'll get a more accurate reading. So you put it on the ear tip. You'll see this in theatres. They might put it on the big toe while they're doing an operation, or again on the ear to measure blood oximetry. Okay, somebody's come back to me and said that you saying about giving 100% oxygen in emergency, could this be harmful? Essentially, in an emergency situation, until the situation can be properly assessed by medical staff and such blood gases, it's better to give a lot of oxygen to somebody because that is what they need at the time. Only 25% of people are CO2 retainers, so you could do more harm than good by restricting the oxygen you give. So the guidelines from Resus UK is that you give high flow oxygen in the initial until you start to determine and assess what actually needs. Somebody's asked in acute lung disorders, can that affect other systems? Of course it can. If you're not getting oxygen circulating around, then you'll get things like, you could get renal shutdown, you certainly would get cardiac problems, the heart won't beat so well and things won't get around the body, and so all major organs start to shut down with respiratory problems and acutely ill. When do you refer people to physio for removal of sputum and chest infections? If they're in the hospital inpatient, the physiotherapist should be seeing everybody who's got chest infection, because it's also about teaching the patients techniques to clear their own sputum. So to assess them, to teach techniques to clear sputum. And please, if you go into a ward area and there's a physio doing some chest physio, go and observe what they're teaching the patients how to. Again, nurses working respiratory like myself in the past, we've been taught by physios how to assist patients clear sputum and how to teach them skills to do that. So yes, they should be seen by the physio. Are low oxygen saturation is always indicative of respiratory infections? No, not always. It's an indication of respiratory problems, but not just respiratory infections. But you would, if an infection gets overwhelming, for saturations to be affected. Difference between BiPAP and CPAP. Okay, so we're talking about non-invasive ventilation, where a machine is put on, the mask is put on a patient's face, and air is forced in. BiPAP means that when they breathe in and breathe out, The alveoli are kept open longer by the air, but there is a degree for the alveoli but they're not kept permanently open where they are with CPAP. CPAP keeps the pressure at a certain, so the alveoli are open all the time. BiPAP mimics normal respiration where there's a period where there's a relax that allows the alveoli to relax, because that's what happens when you breathe. You breathe in, the alveoli stretch out, you breathe out, the alveoli relax, and that's what BiPAP does. When would you use CPAP? It really is determined, and a medical decision on whether to assist people to have their alveoli permanently open to get oxygen in. We're talking about seriously ill people again. Is chain soaking when the body is not given up but the main neurosystem is shut down? On the way to shutting down, Shane, with chain soaking. Okay, if someone's having difficulty in breathing, if SATs are okay, what could it indicate? It would indicate they're having difficulties with breathing, but I would anticipate if they're still struggling to breathe over a period of time, so over the next half hour to an hour, their saturations would be affected. There's no doubt about it. If people have breathing difficulties, they are not going to oxygenate their system as well as if they have normal breathing. I'm going to stop at that point. That was a lot of questions. I'm going to now go on to talk about asthma. We're running out of time. I'm going to go on for a little bit longer. You've asked such a lot of interesting questions. So I'm going to talk about COPD and asthma very briefly. I've been talking about this already. As I said, I'm aware of our time. And there you go. Steady deterioration, airflow obstruction, things do not change, and it's a continual deterioration. Exacerbation means where you're getting a chest infection and then another chest infection, and things will deteriorate. It is said that you never fully recover from an exacerbation, and that there's a continual deterioration. COPD is caused explicitly by smoking or the absence of an enzyme in the surfactant in the alveoli, which keep the alveoli open. There's a relationship there. Most people aren't diagnosed until their late 50s, and COPD is largely preventable. It's preventable, it's related to smoking. So when you inhale cigarette smoke, you're paralysing your cilia, and eventually your cilia stop functioning. So wafting any debris or any kind of infectious bugs type things upwards that cilia do stops. The other thing that smoking also does is cause direct destruction of the alveoli, and the alveoli deteriorate, and therefore the blood vessels around the alveoli stop to not function so well, and the more you continue, the more alveoli you destroy. It is a disease that is progressive and degenerating. A large number of the population do. There are other risk factors. Well, it's to do with smoking, because people who are in poverty tend to smoke more. More men have smoked in the past, but these are figures are predicted to change as more women that smoke. Again, occupation, housing, climate, and potentially childhood respiratory illnesses, and also in utero exposure to smoking. Quite a contributing risk factors with this. So, chronic bronchitis, chronic obstructive pulmonary disease are two things. Chronic bronchitis. So again, coughing, this productive cough that continues, excess mucus secretions. Emphysema, I've talked about this, the alveoli deteriorating. I've talked about the lack of alpha antitrypsin enzyme that produces surfactant to keep the alveoli open and tension there. So the two of them go hand in hand. Alveoli start to deteriorate and you get patchy deterioration of them, and then the airways narrow because you have continual chronic chest infections. And then you get uneven ventilation and damaged alveoli kind of stick together, and once combined, it's recognised as COPD. So what do we see? Difficulty in breathing. We've talked about cyanosis. The reason we get weight loss is multi reasons, but the bottom line is about whenever you've had a cold or a chest infection, it is difficult to eat and breathe when you've got blocked up noses, or it's difficult to breathe and eat at the same time, and therefore it's an effort to eat, and therefore people tend to not eat very much. They also tend to eat things that are convenience foods, maybe little and often, and the other thing, so their nutrition, very poor nutrition, very underestimated, and nutritional assessment is quite a key, really. Barrel chest, this is to do with excessive using the accessory muscles, ventilation, the intercostal muscles and the shoulder girdle, and breathing and breathing and breathing. And what happens is that the intercostal muscles between your ribs start to become hard, and you end up with this barrel chest. We've talked about pursed-lip breathing. We've talked about hypoxemia. Hypercapnia is a rising CO2 level. But essentially, you take a breath in, gaseous exchange takes place, oxygen goes into the bloodstream, CO2 comes out. With reduced capacity for gaseous exchange, not all the CO2 crosses over, and the blood will move on, retaining CO2. That's what we mean by retaining. Hypercapnia is high CO2. And I've talked about the spirometry. So essentially, if you're struggling to breathe and it's very difficult, you start to become tired and exhausted. It is very, very frightening. People will get panic attacks and be very panicky when they're having problems breathing and things don't seem to improve. The other thing with cold temperature and air pollution. And this is also around asthmatics as well. So here we are now in April. Some days are warm, some days are cold. These big swings in temperature changes do not help people with COPD or asthma. Reduced quality of life because you can't walk very far. It becomes difficult to wash yourselves, eating and cooking. The other thing is you get exhausted cooking around the kitchen, and you'll find people with COPD also become reclusive and don't go out, and there's a whole range of things. So it's irreversible. You can reduce the damage by stopping smoking. Oxygen therapy, bronchodilators can help. That's opening the air passages. This is through nebulizers or inhalers. Again, people are prescribed steroids, anti-inflammatories to help during the exacerbations. Already you've highlighted non-invasive ventilation, and I've talked about that. Somebody dies every 20 minutes. These are 2010 figures. There has been no further reports. I had just one last check this morning. There have been no further reports since 2010, which is in itself is very interesting. And this this investigation, wide investigation, was undertaken by the British Thoracic Society on behalf of the National Institute of Clinical Excellence. And there's some people being critical, but that was 2010. Well, what about now? But this is what we have. Interesting here, 15% die within 3 months after being in hospital. So in 2010, this is what the costs were. Working days, sorry about the typo there. And the other thing is we have this thing with revolving door syndrome as well with COPD. Things have changed because we have a focus in the community services about supporting people with COPD more in the home, training them to recognise that an exacerbation is coming on and to take action. And you may well see people having things like antibiotics at home, steroids at home, ready to take should they get an attack. There's telehealth and telemedicine where people are regularly screened in their own home using equipment to check their blood pressure and their SATs and things and recorded. So there's a lot being put in since 2010 to help keep people at home and to improve their quality of life. And should we have the time, I could talk quite a lot about that. I'll talk briefly about asthma. Always, whenever I do this talk, there's quite a lot of people who, quite a lot of students that have asthma and manage their symptoms as best they can. And I hope you're not having difficulty with the weather the way it's been at the moment. Wheezing, breathlessness due to intermittent narrowing of the airways can be reversible, but may need treatment. So you often see children with asthma. Sometimes they grow out of it, and a lot of you I'm talking to who have asthma may have had problems since your childhood. What you've done and what we will have done with healthcare professionals, identify things that trigger it. And again, there's hay fever, season pollen, and things like that, house mites and dust and all that kind of stuff. And what happens is when you become exposed, your mucosa inflame as a allergic action, and you get narrowing of the air passages, hypersecretion of mucus, breathing difficulties. So sometimes people older, so quite often people in their sort of late 40s, 50s develop asthma. It's an interesting one. And you know that if you read into it, so it's worth having a look at this actually, because it talks about you may have had a virus, you may have had something happening, and then you'll be resultant in having wheezing and breathlessness. And again, antibiotic treatment for this isn't always appropriate because it's a virus. So asthma any age, common in younger boys. Things might change after puberty. Middle-age asthma, which is what I've just described, common in women. These figures are 2 years old. You go on to the Asthma UK website, you'll find lots and lots of information. So problems during an attack, the spasm, the edema, and the mucus production, which can plug the alveoli. So air isn't getting in and out, and therefore you're going to get poor gaseous exchange and poor oxygenation, airway obstruction. So high levels of oxygen but monitor the blood gases. Inhalers, they're around. There's ones to B2 antagonists, relax the muscles. Steroids, again, short courses will reduce the inflammation, and again their leukotrienes are used for inflammation. And you can have long-acting ones for long term. So the differences. So COPD and asthma is reversible, but obviously you ought to think about lifestyle, change the lifestyle. Again, self-management, recognizing early signs, doing something about it. Again, asthmatics will have this stepwise therapy to start antibiotics and steroids early should things start to get bad. That was a whistle-stop tour. I'm aware I'm running over time. I'm going to just spend a little bit having a look at your final questions and see. These things, this is really just to sort of kickstart a feature and a focus about respiratory assessment and the importance of it. I do return again to you to talk a little bit more about long-term conditions and the management of long-term respiratory problems, because COPD is not the obviously easy one. Okay, somebody's asking about the effective enzyme. I think I went back and said it's only something like 2%. I might be wrong there. Oh, right, interesting one. Can alveoli be renewed? No. Once they're dead, and they look like you know when you've blown a balloon up and let it down and it's all hanging, all the elasticity's gone. It's a bit like that. How does housing affect COPD, the mold? Yeah, how poor housing conditions, yeah, difficulty and yeah, with the breathing and things like that. COPD is emphysema and chronic bronchitis. It's not called COPD unless you've got the two together. Can asthma become COPD in later life? You can get deterioration of alveoli and asthma, but it could be one of the things I wanted to highlight. You may well have heard in the news that it's difficult to difficult to determine asthma in young children because you can't use, if a child can't use do the breathing into the machines, the spirometry and things like that, you have to diagnose it based on clinical signs. And what they're saying is that GPs are diagnosing asthma for children inappropriately, and there's a call for better diagnostic tools for asthma. So in terms of whether somebody had asthma and it turns into COPD, if they're a smoker, yes. But I would say if people, excuse me, I've got to cough now. If people have been diagnosed as asthma when actually they may have COPD, that often happens. So, I talked about later life asthma. It could actually be COPD. So, close diagnosis, spirometry and gases and things like that. Yeah, somebody's talking about putting prices on cigarettes. And that's, and also, I'm not trying to be doom and gloom about COPD, but if you do smoke, you are at risk. I mean, I've been a smoker and I haven't smoked for 15 years, but I'm still at risk of developing COPD. And I often find if I get a cold, it goes onto my chest now. And that's me thinking, I am at risk of having COPD, even though I've given up smoking. And the government should put more money on cigarettes. Hang on a second. So that is very true, and we ask for that, but enormous amount of tax revenue comes from smoking and people that smoke and their cigarette taxes. And if the government really wanted to stop people smoking, they're going to lose a huge amount of revenue. And there's an interesting question. You're asking I'm really pleased. Some of you are asking some really difficult to answer questions, but absolutely wholly appropriate. Why has asthma started in adulthood? Do you know, I've looked at that. They haven't come to it. Only we've done that because one of my friends was diagnosed, and I looked into it for her. And it's not absolutely determinable. But they also talk about environmental aspects, living in pollution. And although down in the southwest we're supposed to have clearer air. Why is an umbrella term used COPD rather than diagnosed emphysema and chronic bronchitis? They go hand in hand. If somebody's just diagnosed as emphysema, I would be concerned that they're missing. It's COPD. It's very interesting. When it used to be called something else in the past. So have a look and see what it says. Excuse me, I've got to cough. No, I'm not developing COPD immediately. Have a drink of water. Sorry if I'm deafening you. Okay. Long-term rhinitis, interesting, and hay fever. You're asking millions of questions. We're well running out of time. Chronic rhinitis is usually due to something going on in the nasal passage, and maybe asthma could be linked to it. Somebody's asked if respiratory rate is important, why do people not record take respiration properly? Things have improved quite a lot since we brought in early warning scores, but I'd still challenge that people aren't necessarily taking notes. If you look at the early warning score chart and look at the small change in respiratory rate, it doesn't take much for it to be one of the triggers. And by having it as part of early warning score, it is making people actually do better respiratory observations. There's lots of questions about, or not so much questions, people saying about, something ought to be done to stop people smoking, etc., etc. Somebody's talked about overseas where they don't have NHS, when high levels of smoking. Yeah, it does quite surprise you when you see lots of people smoking when you go abroad. Croup is interesting. Somebody's asked if COPD used to be called croup. Croup is a childhood illness where you get high temperatures, high breathing problems, so as a result of a chest infection. And it's a term used for childhood breathing difficulties, not related to COPD. So I'm just going to close my questions. Some bits and pieces about oxygen therapy there. If you want to I'll get Caroline to do two things. One, to put the recording on, two, to put this presentation on, because I've done a presentation here all about oxygen therapy, and that will answer quite a few of the questions that you're asking. This is a skills, respiratory skills for nurses, again. But two things here. Want to know anything about COPD? Go to COPD Exchange. All sorts of little mini courses, teaching aids, etc., etc. Really, really good. Some of these other things are of use. This is nice guidelines. Nice guidelines for COPD. Again, nice guidelines for asthma. There's some new stuff around combination inhalers for COPD. Our time is coming to an end. It's been interesting talking to you. I'll put that back on and say wave goodbye. Always, I could talk for ages about this topic area. I'm hoping it's given you a chance to have a little think and to stimulate you to look more into COPD, and certainly to have a little bit more of a look at patients that you come across respiratory problems, and have a look into their case histories and look into their assessments. As I say, this is a taster, a stimulator, a springboard for you to look into things a lot more, because you will come across respiratory disorders in your careers. There's no doubt about it. Thank you very much, everyone. I'm going to say goodbye now. And sign off. I'm going to stop the recording.